Hello, my name is Holly Howard, and I'm from the California Department of Public Health STD Control Branch. Today I'm going to talk to you about how you can improve your retesting rates among your patients treated for chlamydia and gonorrhea infections. The purpose of the retest is to detect another incidence of the same type of infection, also referred to as a reinfection. To understand why retesting is important, we need to first understand why reinfections with chlamydia and gonorrhea are so very dangerous, especially for women. We know that infections with chlamydia and gonorrhea in general can lead to a multitude of adverse outcomes for women, men, and for newborns. Women bear the majority risk for these complications, as untreated genital infections can migrate to the upper reproductive tract and develop into pelvic inflammatory disease, or PID, which in turn can cause permanent damage to the fallopian tubes, uterus, and surrounding tissues, and can lead to chronic pelvic pain, tubal infertility, and potentially fatal ectopic pregnancy. But are reinfections any more dangerous than an initial infection with chlamydia and gonorrhea? The answer is yes. Reinfections with chlamydia and gonorrhea are associated with much higher rates of PID and ectopic pregnancy. This slide shows results from a research study that measured the relative risk for PID and ectopic pregnancy after a woman's first chlamydia infection compared to subsequent reinfections. What researchers found was that having a second infection resulted in 4 times the risk of PID and twice the risk of ectopic pregnancy. Having 3 or more infections led to a 6 times risk for PID and 5 times the risk for ectopic pregnancy. And this is especially concerning because reinfections are very common. While baseline infection rates with chlamydia hover around 5% for young women in our general family planning settings, when you retest those patients a few months after treatment, their reinfection rates can be as high as 15 to 20%. Significantly, unlike baseline infection rates, which vary widely across patient demographic factors, reinfection rates are high across all age groups and across all racial ethnic groups. So why are reinfections so common? How does reinfection occur? There are numerous reasons why we continue to see high incidence of reinfection with chlamydia and gonorrhea, and probably the most likely is the index patient having an ongoing sexual relationship with an untreated partner. There are many different strategies for getting partners treated, and partner treatment is a priority intervention in preventing reinfections. However, treating 100% of current partners isn't always possible. Other patient factors that can lead to reinfection include sex with a treated partner who has other untreated sex partners on the side, and sex with a new partner who is infected. Sex too soon after the patient or her partner finished treatment is another common cause of reinfection. And while not common, occasionally we can expect treatment failure, which would lead to persistent infection. Additional factors that contribute to the likelihood of reinfection include the patient not grasping the seriousness of her infection or her high risk of reinfection, and power differentials between a patient and her partner, including intimate partner violence, may affect a patient's ability to protect herself from STD acquisition. Adding to their threat, like primary infections with chlamydia and gonorrhea, about 80% of reinfections in women are asymptomatic, so without noticeable symptoms. And that means a person is very unlikely to know when she's infected, and therefore unlikely to seek clinical services as a result of feeling that something is wrong. For all of these reasons, instituting a follow-up retest a few months after treatment has become a key strategy in the fight against chlamydia and gonorrhea and resulting adverse outcomes. Retesting can lead to the early detection and treatment of reinfections, reducing the chance of further complications developing. CDC has recommended chlamydia and gonorrhea retesting for over 10 years, with their most current guidelines specifying that retesting occur approximately 3 months post-treatment and that retesting be a priority for providers. If the patient isn't able to be retested at 3 months, it is important to opportunistically retest them whenever they next come back, as long as it's at least 1 month after treatment. Yet, in spite of the evidence and the recommendations, retesting rates remain very low in most clinical settings across the country. This graphic shows the 1 to 6 month retesting rate in the California family planning setting over the past number of years. You can see that there's been very little change in these rates over time, and they continue to hover way down between 35 and 45%. So why are retesting rates so low? Is the problem on the patient side? Are patients not coming back to the clinic for their recommended retesting visit? Or do clinics play a role? Are there opportunities for retesting that clinics are just missing? To answer these questions, we reviewed thousands of records for chlamydia-positive female patients within the California family planning setting. First, we looked at the proportion of patients who returned to the clinic during their target retest window of about 1 to 6 months post-treatment. 60% returned, but 40% did not. So obviously, we have some work to do to try to get more patients to return to the clinic for their retest. But if only the patients were the problem, then our overall retesting rate should be closer to this 60%, and we know they're much lower. So then we looked at the clinic side of things. And what we found was that while clinics were successfully retesting about 70% of their patients who were returning, they were missing about a third. So the clinics also have some work to do on their side to close this clinical gap and reduce these missed opportunities. Factors at a variety of levels can result in low retesting rates. At the organization or agency level for your clinical site, there may not be policies in place that include retesting for chlamydia and gonorrhea as a priority clinical service. At the patient level, patients may not understand the importance of retesting. Also at the patient level, a few months after finishing their treatment, patients may not remember that they were supposed to return to the clinic for a retest. And at the clinic level, staff may miss opportunities for retesting patients when they do return. Interventions targeted to various levels of the problem may be needed to effectively address the specific barriers to retesting found in any given clinical setting. So what are the feasible and effective interventions that can be introduced in your clinical setting now? Well, starting at the top, it's recommended that a wise first objective is to obtain buy-in from your medical director, organization, or agency in order to raise the general awareness about the dangers of reinfections and hopefully raise up chlamydia and gonorrhea retesting as a high priority clinical service. One very successful strategy has been to arrange a meeting with the medical director or other key decision makers in your agency, present to them your own clinic-specific data, obtained for instance via chart review, to demonstrate the high chlamydia and gonorrhea reinfection rates in your population, the return rates of patients due for retesting, and any clinical gaps, any clinical service gaps, such as low retesting rates among returning patients. Interventions that target patients and their potential lack of understanding about the importance of retesting includes training all clinical staff on how to provide comprehensive counseling for chlamydia and gonorrhea positive patients at their treatment visits. This would be offering patients information about the dangers of and their high risk for reinfection, their options for getting their partners treated, and why retesting is so important. Additionally, training staff to take a moment to really help patients brainstorm ways they might remember their retest due date has also been shown to be an effective strategy. Another patient-level strategy to increase patients' understanding of the importance of retesting is to revise your patient education materials, such as the fact sheets provided to chlamydia and gonorrhea positive patients. Important steps include updating the fact sheets to reinforce messages around the dangers of reinfection, various partner treatment options, and the importance of retesting, improving the readability level and lowering the literacy level of the forms, and organizing the material in a visually more user-friendly format. It's very useful to pilot test the new forms with chlamydia and gonorrhea infected patients to ensure that intended messages are being understood by this population, and then to revise your forms as needed based on your findings. Turning something that may currently look like this, which is a real example from a large clinical agency we worked with, into something that might look more like this will go a long way in improving patient comprehension of the information included. Templates for suggested fact sheets are available on the website links included on the resource list at the end of this talk. New patient education materials can also be developed. Here are some samples of business card-sized retesting information flip cards that we developed for clinics to hand out to positive patients at the end of their treatment visit and in partnership with the counseling that they were receiving. The retesting messages are reinforced here on the cards, and there's a place on the back of the cards where the clinic staff member can write the month and date when the patient should aim to return for her retest. There is abundant research in the literature supporting the effectiveness of clinical reminders for patients in improving clinic appointment compliance and other patient outcomes. Offering patients the option to receive a retest reminder is one way to improve the likelihood of those patients returning to the clinic at the right time. Not very many clinical settings have the resources to telephone every chlamydia and gonorrhea patient 3 months after their treatment visit to remind them that it's time for their retest. But sending out a letter or even just a simple self-addressed postcard like these, similar to the kind your dentist might use, has been shown to be effective. Additionally, there are a number of newer, more innovative technologies that have proved effective in improving clinical compliance. These days, over 85% of teens and young adults engage in electronic communication, like texting and emailing, which provides a relatively inexpensive way for contacting patients. In a recent study we performed evaluating various interventions for improving retesting rates, 90% of the almost 800 enrolled female patients tested for chlamydia or gonorrhea infection opted to receive a future retest reminder. So patients really want these reminders. Of those patients, 90% requested a text message or an email. That was their preference, especially texts. 10% requested the self-addressed postcard only with no email or text reminder. And in some instances, certain patient populations or clinical settings, like school-based health centers and colleges, for example, experience a major barrier to the 3-month wait time for the retest clinic visit, with patients either forgetting, moving away, or finishing a semester and not continuing at the school during the time their 3-month appointment would be due. A prominent researcher in New York was successful in helping the University of Buffalo increase its retesting rate from 17% to 86%. Through a variety of systems-level interventions at the clinic, including revising patient counseling messages to ask patients to return at 6 weeks instead of at 3 months. This allowed the clinic, to schedule an advanced appointment in their system that same day, and then that advanced appointment triggered the system to generate automated appointment reminders. Offering patients the option to take their retest at home using a self-collected vaginal swab home testing kit is a more resource-intensive intervention, but it effectively removes the time and transportation barriers that patients can experience with coming into the clinic. Self-collected vaginal swabs have demonstrated excellent test performance for chlamydia and gonorrhea and have been shown to be very acceptable to clinical patients and the public via numerous home testing projects. They are FDA cleared if collected in a clinical setting, and home-based collection and postal transport is an option if your laboratory completes a fairly straightforward verification protocol. This intervention is certainly more logistically complicated, but there are numerous resources that can provide guidance for setting up a home testing option for those clinical sites that are interested. And finally, there are a multitude of clinic-side systems-level interventions that have been shown to be very feasible and effective at tightening clinical service gaps and reducing missed opportunities for retesting patients who do return to clinic. To facilitate retesting at all visit types, including limited service visits like pregnancy testing and emergency contraception and birth control refill visits that normally don't involve clinician interaction with the patient, clinic sites can ensure that protocols are in place to allow clinic staff of all levels to accept chlamydia and gonorrhea specimens. These include urine or self-collected vaginal swab-based specimens and having standing orders in place. To increase clinical access, sites can offer walk-in visit hours where no appointments are required for STD testing or retesting of asymptomatic patients. And some clinics have been able to introduce express visits, allowing asymptomatic STD test-only patients to have shortened wait times. To further ensure retesting isn't missed for patients due for this follow-up, clinic sites can introduce streamlined risk assessment procedures at intake during all visit types. This is a photo of a pocket-sized laminated chlamydia gonorrhea risk assessment card that was created as a clinical tool to provide to staff and or affixed to the intake computers, making it more likely that an assessment for screening and retesting was completed at intake for all patients. And a very essential strategy to reducing clinical gaps is adding flags to patient medical record charts to ensure staff will be triggered to retest a patient whenever she next presents to the clinic within her retest target timeframe and regardless of her reason for visit. For paper charts, this could mean inserting a prompt of some sort, such as a bright-colored laminated card that will catch the eye of any staff member who pulls the patient's chart. And automated pop-up reminders can be programmed into electronic medical or billing records for retest patients to alert front office staff at check-in if the patient is due for a retest today. In a recent study evaluating various strategies for improving retesting rates, this one intervention, programming automatic pop-ups that were seen by front office staff right at check-in, was able to reduce the clinic's missed opportunities for retesting by over 50%, from 30% of patients missed before the pop-up interventions to only 14% missed after. Just this one intervention that required no additional cost to the clinic and little logistical intervention made a lasting impact on their retesting rates. Systems-level interventions such as these may have a more consistent impact on improving clinical services, as they do not rely on either the patient remembering to request the service or the clinician's capacity to reliably remember all recommended follow-up protocols. The variety of interventions discussed today are feasible and effective options that can make a big impact on improving patients' understanding of their very real risk for chlamydia and gonorrhea reinfections and in closing substantial clinical service gaps. These are all steps you can take to make a real difference in the health and well-being of your patients. Thank you.